Hello, hello. Good morning to everybody. Welcome to Brussels. I hope my slides will appear. Fabio Taccone will share this introductory welcome, will speak just after me, and we would like to welcome you all very warmly to our 41st ISICEM. It's actually the 42nd year, but you know, we had a difficult year at some point. So it's back to be face-to-face again. Of course, we may not be as numerous as before COVID, but we are pleased to have about 3,000 people now, which is one half of what we had in the last 10 years preceding COVID. Last September, we already had a face-to-face meeting, which was very appreciated, and we had about 1,500 to 2,000 max participants. So it's getting better. Maybe next year, we will go to 5,000 plus. We think that face-to-face meetings are absolutely essential, and many people are a bit fed up with all these video conferences. For those of you who do not know the building well, it's sometimes a little bit tricky. We are here in the square building, and you went through the red registration area, but you must know that there is Beaux-Arts nearby with an underground tunnel. That's usually where we have the opening session when we have more than 6,000 participants. And then there is a tent that you saw when you came in. In this building, it's sometimes a bit tricky to find the room, but you know, look at the signs, which are relatively well done, and you will find some additional information on your app. We do have a fantastic program for you. Excellent updates, and it's time to have updates not only in COVID, but also in other fields. We have 2 simultaneous publications for those who like to see new results of studies that will appear in major journals, and that will be in this session this morning. And we have a program with 779 sessions. Now, meetings are evolving, as we know, and in addition to the standard presentations, we have less and less plenary lectures and more practical sessions with demonstrations, clinical challenges, case discussions. We are here to talk, to discuss, to interact. So we have built these spaces in the exhibition area in particular, and you will find this program in the written material that you received, as well as, of course, on the app. And I would like to take this opportunity to thank our scientific advisors, as we have called them over the years, with diversity, as you can see, and people from all over the world help us to find the best people to have the best program. And I'd like to thank our sponsors. Without them, it would be impossible to have this meeting. And of course, the platinum sponsors are particularly thanked, but you know, the gold sponsors, the silver sponsors are also absolutely wonderful. And we have as many as usual, which is really great. So please find some time to visit the exhibition area and still look at their booth and what they have to propose and perhaps to teach us when we use their material. And in the scientific exhibition, you will always have something to eat, like waffles or ice creams and some water, because we would like you to go there. So I'd like to thank our team, our collaborators, under the leadership of Veronique de Vlaming. They are really excellent, and they work throughout the year to help us with the preparation of this program, and you will meet with Colette, Ina, Marie-Rose, Estelle, Pierre-Yves, and Aldo. So we are really thankful to them. We have a wonderful team. So we are almost in the post-COVID era. And of course, we will speak about COVID, but we will also see what we have done well, what we have done less well, what we should do better the next time. We have been relatively good in preparation. We have not been bad in progress and development of new therapeutic strategies, although we could have done better, especially if there was not this hydroxychloroquine story that really limited our progress initially. Personalization, even though COVID is a single disease, and of course, prioritization with its ethical consequences. How can we organize the ICUs? But also initially, we were thinking that COVID is primarily a lung disease, is a community-acquired pneumonia. But we learned that all organs are involved, and when patients die, they die from multiple organ failure. I was very impressed by this excellent study showing that endotoxin levels are increased in patients with COVID. Endotoxin in a viral disease? Well, it most likely comes from the gut. But that's a very important observation because it links severe COVID to other forms of sepsis that could be bacterial, that could be due to gram-negative. And there is a direct relationship between the amount of endotoxin in the blood and the cytokine levels. This is not a minor publication. It comes from Science. It's a beautiful story that led us to consider COVID-19 as all about sepsis, viral sepsis. And of course, we'll have a lot to discuss. It was a terrible period for us. And towards the end of COVID, there was something very bad that replaced COVID in a way. So we'll have also to address these questions. Of course, we could think at non-combatant status of military medical personnel. And Dr. Reed should have told it himself, but he got the COVID recently, actually, so he could not make it to our meeting. But the point, there is a lot to say about it. I will not expand too much, except to say that doctors should play their role, and they should not give any priority to those who can return to the combat versus the others who cannot. That's one of the things which are very important, and they cannot be prisoner of war. Now, medicine during war, it's not only combat. It's also the care to the public. Many people are traumatized. It may be different types of trauma. It may not be penetrating. It may be more closed trauma if there are explosions or buildings attacked. And refugees pose their problems as well. I was reading yesterday that for diabetic patients, it may become complicated to get enough insulin in these cities. Well, it may not be critical care medicine. Well, yeah, in some way, because they may see more diabetic coma because of the lack of insulin. It's just to give one example. But there are many people who are on corticosteroids, on anti-cancer medication. We need to think at all of this as well. So yesterday, this paper appeared in Critical Care proposing to act now. It is signed by some colleagues from Eastern Europe and Ukraine and the United States. And so we have a special session on medicine during war that will go over these various points. Now, I will take the challenge to make a small parallelism between COVID and war. And that is, in both situations, we may be overwhelmed with victims and sick, traumatized people with difficulties to transfer. When there is a single event, single accident, single explosion, We know in emergency medicine that this is called a hotspot, and we can evacuate people to other hospitals. We had a big accident like this just 2 days ago in Belgium, and there were many victims, and they were transferred to other hospitals. Of course, the less sick going to a further away hospital. But when there is war, it's like when there is COVID. It's really difficult to transfer these patients, and we have to do with what we can do on the spot. And there are difficult triage decisions. Ethical decisions have to be made. And we cannot say that the intensive care unit is full. We should not admit the principle of first come, first served. That would be unfair to those arriving a bit later than the first ones. Likewise, lottery is not a principle that we apply in critical care medicine, because it's not just two identical patients for one bed. We have several beds, but we have many people coming in, so lottery cannot be applied. I was pleased at the beginning of the pandemics to see this article in the New England Journal of Medicine saying no to the first come, first served basis, no to lottery. And this is true also for some techniques. We wrote this piece on ECMO being applied in COVID patients and potentially making a difference to the other patients in the unit, because the personnel will be more concentrated on these ECMO patients. You may say, well, in Ukraine, they will not apply ECMO. Granted, but it could be true for less sophisticated techniques, including renal replacement therapy in patients who may need it. And my third element is the use of telemedicine, that we have started to use more extensively in the COVID period, but this could be used also to help our colleagues in some difficult regions. So there is a lot to say, but these are just a few thoughts to start the meeting. Don't hesitate to tweet and tell the world what you think about the sessions you attend. And please enjoy Brussels. You will find a lively city under the sun. Look at our mannequin piece, he put the right clothes to celebrate our ISICEM. And please note in your diaries that you may be interested in our next meeting in Rome. These consensus brainstorming meetings. The next one will be on the future of intensive care medicine. What about artificial intelligence? What about new technologies? How they will affect our future? And of course, join us for 41 more years. Next year, write the dates. It will be, of course, in March for the 42nd edition. Fabio, are you ready, my good friend? Because the floor is yours.
Oh, thanks. My God, what a challenge being here after my chair and my mentor, Jean-Louis Vincent. I really want to welcome you in Brussels in my Italian way. Buongiorno to everyone. I was thinking what still I have interesting to tell you. Maybe I would like to announce the challenge, an happy hour to everyone. Free Belgian beers 3 times a day during the meeting, but I don't think that Veronique and Jean-Louis would agree with that. So, yeah, I would think that what you have is going back to the application and look at this fantastic program from brain to sepsis to COVID, pick up your preferred session, prepare your menu, and as you have heard, enjoy this meeting. I think that there is also another reasons why this ISICEM will be success, because I was thinking about the number 41, the 41st edition. 41 is a special number because it was the last symphony of Amadeus Mozart. It's a very famous song written by David Matthews Band, for those of you who like rock music. In 41 after Christ, the Emperor Caligula, who burned Rome, was murdered, and as we had a medical meeting, penicillin G has 41 atoms. All the numerical conditions are met to make this ISICEM Congress as a successful event. You have heard that ISICEM is a lot about tradition. We have likely the same chair since years. We are in the same city, almost the same venue, and there are a lot of people who have been there as faculty members to support this meeting. And I think that having the meeting face-to-face, having a connection with those experienced intensivists is a good moment to share with them other experience than medical decision. I'll just pick up two wonderful pieces written by Randy Curtis and Margaret Herridge, who had the opportunity to translate into words how important is the connection with experienced intensivists for younger generation in terms of understanding the interaction with patients and families, understand how important it is to support novice idea, accept failure, and prepare ourselves to be in the future maybe also a good mentor as they have been. And all this is possible thanks to the connection and the face-to-face meeting. I think that of course we lack the evidence. Our discipline has a lot of randomized critical trials that drive our practice, but in some of their lecture, having this opportunity to discuss with the faculty and among us will be also a good moment to maybe challenge some of our dogmas, having a fresh look, revise some of these articles, maybe thinking outside the box. Sometimes critical reflection is an important way to progress in our experience, and face-to-face meetings are important for this. And the last word, I think that going back to this face-to-face meeting is important to think again about scientific communication. I think during the pandemics, we have learned to use social media as the only way to communicate among us, is the only way to share articles, sharing experience, at the moment where there was no way to meet, as we have done in the past. This has been very positive, but we had a payback, a negative payback from the social media. A lot of distortion of reality and misinformation has come back. And unfortunately, sometimes not from unexperienced people, but sometimes also driven by doctors. And this has been underlined by WHO, by the European Concilium. And I think we need to, at this opportunity of face-to-face meeting, to rethink the way that scientific communication is done. And when scientific communication is done properly, so we can share our experience, I think is the basis to think about science communication. It's the way that we can inform, educate, and raise awareness in non-experienced audience on how much critical medicine great is. So enjoy the meeting, and thanks for being there.
So we leave the session to our two moderators this morning, Professor Cacconi, who is from Milan and the president of the European Society of Intensive Care Medicine today, and Jacques Creter, who is our former head of the department now, because he was recently promoted as medical director in our institution, and that's how Fabio became the head of our Department of Intensive Care. So the session will be in good hands, my good friend.
Thank you very much, Jean-Louis, for this nice introduction, and thank you to Fabio, of course, and we are, of course, very happy to see you here in this room in a face-to-face conference. So I don't want to take too much time, and I want to invite the first speaker, which is Thierry Calandra. Thierry Calandra from Lausanne, and the title of his presentation will be Sepsis, What Have We Learned from COVID-19? Thank you, Thierry.
Well, good morning, and thank you very much for the invitation and, in fact, challenge. We all have been struggling during COVID, but one of the struggles was to keep up with the literature. We had an avalanche of articles, and it was very difficult to keep track of all the good work. So please bear with me if I did not select your preferred article. I had to make choices, and I will scratch the surface. There were so many things. Can I have my presentation? Okay. Disclosures, mainly associated with sepsis, International Sepsis Forum. 3 slides to begin with for those who are not familiar with sepsis. This wonderful article by Dr. Rood in the Lancet about sort of global burden of diseases. 50 million sepsis cases, a mortality of 20%. And you have on left and right incidence and mortality. And of course, there are areas of the world, like for COVID, that pay a higher toll than we do in Europe, Northern America. We tended to believe that we were not making progress. This article showed that we did. The mortality decreased by 37% over 30 years, which is outstanding news. We have done, of course, numerous clinical trials targeting the microbe, targeting the host response to try to decrease that mortality. Lots of trials, few successes, stress dose of corticosteroid, activated protein C, to name just 2. Why so many failures? Of course, we acknowledge the fact that there is complex pathogenesis and evolving pathophysiology. Targets are difficult to identify. There is, of course, a high degree of heterogeneity. I'll come back to that in the next slide. Suboptimal preclinical models. We didn't address always the biological plausibility of what we were targeting. And there were issues, numerous ones, with clinical trials, overestimated treatment effect, sample size, timing of the intervention. I will come back to that with COVID. Drug, did we use the right one, the right dose for an appropriate duration of time? And very importantly, because of the heterogeneity, a low signal to background noise ratio. And of course, the endpoints. And towards the end, at every cycle of the investigation, we wondered whether single target therapy could impact on key determinants of all-cause mortality. Sepsis is a syndrome. It's not a disease. And we have learned that even more with COVID-19. There is diversity in the host. There is a high degree of heterogeneity in the pathogens, gram-negative, gram-positive lumped together in a trial. There may be sometimes co-infection with fungi, overlooked viruses, various type of infection, peritonitis, meningitis, bacteremia, lumping them all together. We forgot also the environment, the healthcare system of where the people were living. A syndrome. Lesson number 1, when we are dealing with COVID, we are dealing with a D, with disease. And I've highlighted here the time course. In sepsis, we don't know exactly sometimes in patients, even when they are hospitalized, when it started. In COVID-19, time 0, plus or minus a few days, of course for those who were symptomatic, is fairly precise. We learned that there were 2 phases, the viral phase and the host response phase. We learned that if we were to use antivirals, we should be on the left-hand side, close to time 0. Otherwise, if we apply that later on, remdesivir, for example, well, it was not working as well. For the first 2 wave in my environment, we knew that between day 5 and day 7 to 9, and this was also true for the alpha variants, people will move from the viral phase to the host response. It's not that well defined, of course, in sepsis. And you have the symptoms at the bottom. I'm not showing long COVID. Long COVID is very important. We are targeting that, and it's going to help us for sepsis survivors who have poor outcome. Jean-Louis addressed that before. Is it a good model for sepsis? Is it a good proof of concept model? Here are some views from Dr. Rhee, Jean-Louis Vincent, it's all about sepsis, as well as here a review of the signs, symptoms. As you can see on the right-hand side, 80% in this meta-analysis, patients during the first wave, Wuhan strain and alpha, have sepsis. They have ARDS. Septic shock is a bit high. In our environment, it was a bit lower. They get to the ICU about 20%, and the mortality was quite high. We knew viruses cause sepsis before. It has been absolutely fantastic, the amount of knowledge that became available very rapidly about the receptors, the core receptors, the way the virus fights the innate immune response, the pathway that have been activated, and the identification of multiple potential targets, some of which have been targets investigated in sepsis trials. This has been absolutely spectacular. Well, let me show you one work that we did together with our CU colleagues and immunologists, and in collaboration with investigator in Paris. We used 3 cohorts of COVID-19 patients, more than 200 patients together, almost 500 healthy subjects as controls. We sampled at the time of admissions. We did cellular markers with mass cytometry. We did Luminex, 49 serum markers that we can get access to in real time in my environment. We found differences between healthy controls, non-ICU COVID patients, and ICU COVID patients. Some mediators, 5 of them were going down. 15 were going up. Interestingly enough, there were names on this list like hepatocyte growth factor that I had personally not heard about before. We could see that HGF and 2 chemokines were much higher in ICU than non-ICU patients. You would say, well, we have seen that before. Is it really new information? You have the ROC curve and the area under the ROC curve for predicting severity, i.e. admission to the ICU. HGF 0.93, CXCL 13.87, CXCL 9.86. IL-6 came next. So the ratio between HGF and CXCL 13 was predictive of outcome as well. But there was also striking observations. If you look at TNF value on the left, IL-6 and IL-1 here, alpha, well, they were not very elevated. They were in the picogram range. Compared to what we had done years ago in gram-negative sepsis, on a log scale in gram-negative sepsis, 1 or 2 log higher in terms of TNF, IL-1, and IL-6. Many others made the same observation. Cox, Leisman in a meta-analysis. So shall we talk about cytokine storm, cytokine release syndrome? You know, or like Daniel Remick said, well, cytokine drizzle, in fact. And Caroline Calfee and Michael Mattersell, is cytokine storm relevant for COVID-19? They ended up their editorial with tempest in a teapot. I think we should get rid of the cytokine storm term that seems to encapsulate a concept about pathophysiology, but there is no definition about that. Now let's keep in mind low cytokine levels. And dexamethasone was shown by the recovery collaborative group to be playing an important role in decreasing mortality. You are well aware of the various category on the right-hand side, no oxygen delivery. A worse outcome, perhaps, with dexamethasone, timing of administration. But again, low cytokine level, dexamethasone, high dose for 10 days. Well, we had been arguing, why did the various corticosteroid stress dose trials work or didn't work? Are these COVID-19 data telling us if the cytokine level are lower in COVID-19 and Dex was working, that we may have used either the wrong one or at a too low dose to downregulate cytokine production? Now, Dr. Gordon put a very nice editorial. Understanding sepsis endotype is important. Yes, it is. And Dr. Sinha with Caroline Calfee and others showed very nicely, first in 39 patients in Lancet Respiratory Medicine and later in 483 individuals, that indeed this subgroup classification is important for response to therapy. You have the classical hypo-inflammatory and hyperinflammatory response that have been demonstrated in ARDS, and COVID-associated ARDS was going the same way. As you can see at the bottom part, using corticosteroids in class 1 had no impact on outcome, perhaps even increasing slightly mortality compared to class 2 who benefited from the approach. Subcategories, subtypes. A wonderful piece of work done again in the UK. The UK has been doing a fantastic job during the pandemic. Congratulations. This was an example for the world. Blood atlas of COVID-19 here. 116 hospitalized COVID-19 patients, mortality 23. An article with 82 pages. I went through that. And they tried to categorize host responses through clinical data, mass cytometry, all the omics. Terrific piece of work, trying to dissect out community versus hospitalized with mild, severe, or critical COVID versus healthy versus sepsis versus flu. Wonderful paper. They find out that activated CD4 and CD8 cells that were upregulated, decrease of non-classical monocytes, AP1 transcription factor and MAP kinase, as well as CD49 to CD43 ratio, were important to segregate between COVID, normal host, flu, and sepsis. With that, of course, we can go ahead and characterize better our septic patients. Wonderful editorial by Chris Seymour, who has been a lead investigator in the field. There is now almost 60 phenotype, endotype, or subtype described in COVID-19. Is that meaningful? What should we do? Here, he suggested 5 essential steps for defining useful subtype criteria. Biological plausibility, promptly identified, non-synonymous, reproducible, and treatment responsive. I think this is what we should do. I cannot end without talking about the wonderful platform trials that were developed by, again, our UK colleagues. The Recovery, almost 50,000 participants in their studies. Also at the WHO Solidarity trials, a bit less. Fantastic work by Remap Cap investigators, 12,000 more sites than on the UK side. This was pragmatic approaches. Recruitments were simple, fast, and really inclusive. Adaptive design, no time to go over that, I'm not an expert. randomized control open label trials, large sample size, you could do some subgroup analysis, and they address key therapeutic questions in real time. How wonderful. Look at the sample size that allowed us to kick out some of the drugs that we considered upfront for use: aspirin, hydroxychloroquine, lopinavir, ritonavir, azithromycin, colchicine, and later convalescent plasma. Dexamethasone worked. Tocilizumab, positive result. Baricitinib, and a combination of monoclonal antibody. Absolutely outstanding. In short period of time, we had answers to some questions. Well, we may see the glass half empty or half full. Of course, there are, in terms of methodology, concurrent control group. Are they really comparable? I'm not familiar with statistics, but there were issues with shared control groups, adjustment for multiplicity. Of course, this is a traditional endpoint, 28-day all-cause mortality. There were no long-term follow-up. Perhaps we should do biobanking in real time to the extent that we can do. It defines also standard of care. And there are ethical challenges to study the heterogeneity of treatment effects once you have established standard of care. This is not easy. And do we need confirmatory trials? Learning from COVID, there are limitations and caveats, of course. We worked in a pandemic setting. SARS is evolving, we know that. There are variants of concern with different characteristics in terms of transmission, virulence. Host immunity, we started from naive to now immunized, but immunized by natural infection, by vaccine. Sometimes heterologous vaccine have been used. A combination hybrid immunity, natural with vaccine. And what is the relevance of what we observed that has disappeared in the meantime and doesn't exist anymore? And this is really relevant for bacterial and fungal sepsis. Of course, there are other lessons. We had an intense emotional pressure to be proactive. We were overactive sometimes. We had a plethora of proposed intervention. I took that illustration from an article by Dr. Snow and Dr. Singer showing that sometimes we were considering either blocking or stimulating the same receptors. There were numerous trials with questionable, rational, poor design, underpowered, and few were completed. And also, and this is a quotation by Dr. Hobie from Oxford, poorly used and sometimes wasted resources. So COVID-19 should also learn from sepsis, not only sepsis from COVID-19 in terms of what we do. Well, which route should we go next? Should we continue to follow the left-hand side, work with a sepsis syndrome, have multiple types of infection, multiple pathogens, high degree of heterogeneity, low signal to background ratio? Some would argue that, well, it's doable, provided we have the number, we can identify some common pathway to all of these clinical entities and pathogens. I prefer to go the right route in green with specific diseases like COVID, single type of pathogens with one or few, low degree of heterogeneity and high signal to background ratio. What did we learn? I summarize, 80% of COVID-19 patients in the first waves, of course, had sepsis, one pathogen but several variants, a moving picture. Low level of heterogeneity or lower than with bacterial sepsis, proof of concept model, powerful genomic, genetic, and multi-omic study have been useful to identify similarity and specific features. I have highlighted HEF and CXCL13 as an example of a useful biomarker, perhaps adding some pathophysiological content in the sense of a counter-regulatory diet for systemic or lung inflammation. Cytokine levels were low. We can disregard cytokine storm. the power of platform trial, there were several immune-modulating therapies shown to be efficacious using the platform trial. So these are lessons for sepsis from COVID. The question is, but will we learn? Hopefully so. Thank you very much.
Terry, thank you for a fantastic presentation, for going through the last 2 years in all this detail. For the sake of time, we have to move on, so it's a great pleasure to introduce Lenny Derde from Utrecht. Lenny is a friend, is an intensivist. She's also involved with the European Society of Intensive Care Medicine. But overall, I would say their contribution that she brought over the last 2 years in research in this pandemic has been outstanding, and I think she's going to tell us a little bit about that. Lenny.
Thank you very much, Maurizio. I'm trying to get my slides up. This is not my slide, but I hope you enjoyed it. I'm sorry, I can't seem to... I'll give you a minute to relax while I sort out the slides. Just to start talking, it's not functioning anymore. Sorry for this slight technical issue. I don't have control over the laptop anymore. The mouse is not working. Sorry for that. I hope somebody can help me from the back of the room. And in the meantime, I'm going to tell you that I hope that this presentation I'm going to give will nicely follow up from what Professor Calandra has just told you. It's not.
Then I think we can move to the questions.
Yeah, that's great. I'll take any questions now. I'm sorry
jokes aside, you want to tell us, how were you ready with Remap Cap
yes,
before the pandemic?
So I'm not going to disclose everything I was going to tell in the presentation, but I think one of the things we did is we did look back at the pandemic before that, but I'll tell you more about it in a second because I have my slides up, at least on that screen, so that's fantastic. So research will be much improved in the next pandemic. I could leave you with that statement and just say that I'm an optimist, but what I would like to do is take you back in time a little bit and do some time traveling with you. And not just to the beginning of this pandemic, but related to the question that Maurizio just asked me, going back to the previous pandemic, the influenza A H1N1 pandemic in 2009. And I'm going to focus myself on therapeutic intervention trials. I'll touch on other subjects a little bit. So in the 2009 Mexican flu pandemic, hardly any therapeutic intervention research was done. If you look at this figure adapted from a manuscript by the group of Peter Horby, you'll see that only about 2,000 patients, so this is patients, not trials, were included in therapeutic intervention research in that pandemic. And out of those 2,000, only 153 were included in trials that were eventually published. 153 patients. None of that research came out during that pandemic. And that pandemic was admittedly less disruptive than this one, but it still took about a year and overwhelmed our ICUs severely. So I think after that pandemic, the conclusion was that maybe randomized controlled trials could not really be done in a pandemic. You know, the research enterprise was a little bit broken, like this car on the picture. So let me time travel with you again to the beginning of this pandemic. What had we learned from the previous pandemic, and how did we get into the research that we wanted to do? So there were a lot of things that were much improved. And as I said, I'm going to step outside of the therapeutic intervention trials for a little bit. This is a publication from February 2020 in JAMA, and I really like this picture because it compares the Sars epidemic to the current COVID-19 pandemic that had just started in early 2020 when this was published. And what you can see is that the speed of science was just absolutely amazing. While in the SARS pandemic, it took several months for us to get a grip on the virus. In this pandemic, after the report to the WHO of this possible new infectious virus, within a week, the virus was known. And I think about 2 or 3 weeks later, the full genome of that virus was sequenced. So that's absolutely amazing. Another thing is, that was really amazing is the number of trials that was started. So this is a picture from the WHO website that registers every clinical trial on COVID-19 across the globe. And what you can see is that there's almost 4,000 clinical trials ongoing across the globe. Just under half of these are still recruiting patients. That's a vast number of trials. That's a lot of information. But there is also bad news, because these trials are not connected. There's no coordination. There are a lot of loose ends and redundant circuits. And I'll try and be a little bit more scientific about that. If you look at this figure from a manuscript by the FDA investigators, one of them was Janet Woodcock from the FDA, what they did is they looked at all the trials that were registered for COVID-19. And they identified how many treatment arms there were in all these trials. And they identified almost 3,000 treatment arms. Out of these almost 3,000 arms, 5% was adequately powered and randomized, 5%. Only about a quarter of over 530,000 patients contributed to those trials. The rest is research waste. All the other trials were set up to fail. They were not adequately powered and randomized, which is kind of the first thing you have to do if you set up a randomized clinical trial. And also, if you look at that website by the WHO that I just showed you, you can see that the sample size of most of these trials is very small. There's a limited number of trials that aim to include more than just a couple of hundred patients. So there's a lot of research waste, and many trials were set up to fail. That's not good news. So why is that? Why weren't we able to set up good trials? So I think many of these trials fail to address the specific challenges of doing research in a pandemic. And there are 5 challenges of research in a pandemic on top of the normal challenges. The first challenge is you can't see everything, right? So you have half the information. You don't know the disease. How are you going to calculate a sample size? The standard of care is going to change during the pandemic. How are you going to adapt to that? You have to make 100% of your decisions with 50% of the information. Everything is kind of blurry. It's like hitting a moving target. So that's challenge number 1. Challenge number 2 is you need a one-stop shop. Because in a pandemic, and if you think about the last 2 years, you know that lots of potential therapies will arise. And if you have to think, 3 months about the ideal compound to investigate in your trial, then you'll waste a lot of time and you'll likely miss one because you can't select the most promising intervention up front. You can have an idea of what works by preclinical research, but you don't know what's going to work. I think if 2 years ago we would have asked this audience, what do you think will work? Will it work to kind of suppress the immune system of severely ill, critically ill patients without giving them an antiviral? Most would have said no. In the end, that's what we end up with. So you need, a cart, a basket. You need a one-stop shop. You need to be able to investigate multiple potential therapies at the same time, and preferably in interaction with each other. The third challenge in a pandemic is the research has to be embedded, and Professor Calandra also alluded to this in his talk. So this is a picture of our ICU when we scaled up during the first wave. So this is an outside ICU location. And what you can see is, next to the slight anxiety in the eyes of one of my colleagues, you can see that it's literally 11:45. All the hands are needed at the bedside. Nobody has time to do research. We need to take care of an immense number of patients. So the research we do has to be a bit pragmatic. It has to fit in with clinical care. You can't spend time filling in a 100-page CRF. It has to be embedded. That's what we call that. The fourth challenge is perfect is the enemy of the good. If you want to build the perfect cathedral, it'll look fabulous, but it'll take a very, very long time. And you don't have the luxury of time in a pandemic. So you may have to accept that your trial is going to be good enough, but not perfect, to get things done. And in the end, you may think that that's better than designing a perfect trial but never getting it up and running because the pandemic is over. This has been the kind of mistake that we've made in the influenza AH1N1 pandemic, I think. There was a lot of great research planned, but there was just no time to execute it because we wanted it to be perfect. So one of the examples is, for instance, in a randomized clinical trial, it can be very attractive to use a placebo. But the placebo is also very difficult to organize. It adds to cost, it adds to logistic, it adds to the complexity of the trial. And maybe in some cases you can accept not doing a placebo, but getting your trial done, which may be an important choice. And the last challenge of doing research in a pandemic is that viruses don't respect borders. Viruses are not contained to your country, they affect the whole world. So you have to cast a big tent, you have to collaborate internationally. I think that's a very important point I wanted to make. So back to the future again, back to now. If we look back at the pandemic, are there things we could have done better? Are there things we have learned, and how can we take this into the future? I think we've learned a couple of things, and what I've done is I've tried to kind of take the process of doing a clinical trial from start to finish, and then talk to you about what I think the challenges are and how we can maybe address those. So at the very start of any trial or research is an idea, a clinically relevant question that we want to answer. And in this pandemic, we've learned that there's no shortage of ideas, but the problem was prioritization. How do you know which compound to investigate? And I think there should possibly be something like a pandemic research authority, much like the UK CTAP, that kind of pools all the preclinical research, has experts review that evidence, and then say, well, these compounds are things you should evaluate in a trial, these are less promising. If you think about the one-stop shop, you can still be wrong. That's why we do the clinical trial, to get the answer whether or not it works. But I think it's good to have prioritization and not investigate. Well, we've had proposals from anything from kombucha to to cord blood and I don't know what, but those were rejected, I will tell you, by the trial I was working in for the last 2 years. The other thing is, if you have a good idea, that's the point to start collaborating. Internationally, as I just said, also collaborate with patients to see what useful outcomes are to them. And I think we've seen a lot of great examples of collaboration in this pandemic. It can still be much improved, but we've seen examples of successful prospective meta-analysis, multi-platform RCTs, and I think those are all examples of great collaboration that we need. The second stage of a clinical trial is funding. You need to acquire funding. And there was enough money available, at least in the Western world, for research during this pandemic, but grant writing still takes time. And if you have to scale up in a pandemic while you're still trying to acquire the funds, not knowing if you can actually pay that personnel, that's very challenging. So the European Commission is working on that by establishing the HERA incubator, and they're also trying to talk to the member states to connect national funding to European funding, because it just doesn't make sense if a member state in the European Union has a different goal, wants to fund different things than the bigger picture, and then we're just talking about Europe and not even globally. Something that may sound controversial is I do think we have to fund networks that have delivered before. If you have to set up your whole network during a pandemic, that will fail. You have to fund networks that have delivered before. I think many of the successful trials in this pandemic had an established network, even if they still had to scale up. The third aspect of clinical trials is the setup, the design. And Professor Calandra already talked a little bit about this. Many of the successful trials in this pandemic have been platform trials or adaptive platform trials, or some version of that. Recovery is a platform trial, Discovery, Solidarity, Remap Cap, all platform trials. And they are embedded, and to a certain point also all pragmatic. So now you can see that the further we get into this process, the more I will refer to things I've said before. Viruses don't respect borders, so also in the setup you need an international approach. And what I really want to say is you also need to address inequality. So we can't stick to just Belgium or just Europe. We have to consider that this pandemic affects also less well-off countries, and we have to give them a chance to participate in our research, and we have to try and address inequality. I think this has become most clear in this pandemic with the vaccine story. Still large parts of Africa haven't been vaccinated while we've all been double vaccinated and boosted. I wanted to show you 2 slides about this design. To explain to you what adaptive platform trials are. Adaptive platform trials are a subset of randomized controlled trials. That's what you have to remember. and they have two kind of smart features. The first is they work under a master or core protocol, much like basket or umbrella trials, and the second is they have adaptive features. Adaptive features means you are allowed to learn while the trial runs, which is extremely efficient in a pandemic, but maybe also outside of a pandemic. What you do is you use the data that accrue in the trial in a robust and pre-specified way to learn which direction to take, which makes you much more flexible, efficient, and drops ineffective therapies quickly. What it also does is it tries to address a little bit an age-old dilemma that we have, and this is called the exploitation-exploration trade-off, where doctors have two kinds of thinking. The first is we have to do something, we have to give the patient something, even if we're not sure that it will work, we have to do something. The other vision is we have to learn. We're not going to give this patient anything, first do no harm, we have to find out if it works first and then we'll give it. So these visions are traditionally represented as opposing. But adaptive platform trials can help bring those boxing gloves together to fight the common enemy and create a kind of learning while doing system, a kind of a learning healthcare system. If you want to read about that, the reference gives you the link to a very elegant piece that Derek Angus wrote about this last year, or actually almost 2 years ago now, in JAMA. And I think that is kind of the philosophy of the design of adaptive platform trials. If we go further into the process of RCTs, there's the delivery of the trial. That's the key. You can have all these other things sorted, but if you don't deliver that trial, then you're not going to have any results. And for that, you need operational infrastructure, right? You need like your stadium, the build of the trial. It needs to be simple, preferably but digital. And what we've learned in the last 2 years is despite all kinds of efforts, there's still a lot of what we call PEARL hurdles. So PEARL is political, ethical, administrative, regulatory, and legal. So these hurdles have to be overcome. That cannot be done on a trial-by-trial basis. That's really a kind of higher level things that need to change. And about that operational infrastructure for the delivery, I wanted to tell you about, I see that as a stadium. And what we do now in randomized controlled trials is we build a stadium for that trial. And when the trial is over, we kind of demolish the stadium and we start again. That doesn't make sense. It's much more efficient and it will help you in a pandemic if that operational infrastructure, if that stadium is still standing. And you can play multiple games, even host a pop concert if you want to. So the conclusions, I think we've done pretty well there in this pandemic. So early disclosure of results is obviously very important. It's shocking to realize that there was no information during the influenza A H1N1 pandemic in 2009 during the pandemic. I think we've made better use of preprints than we did before. There's all kinds of discussions you can have about that, but it's a good idea. Journals have played their part by making the data open access, and I think trial groups have collaborated to quickly uptake the results into guidelines, and there's also been a lot of leadership from the WHO in this. So how do we get from this kind of disorganized, huge number of trials with all these loose ends to this kind of connected, future-proof way of doing research? I don't know the answer to that, and there's probably many, many answers, but there are things that can help, and the key is in collaboration, I think. One of the initiatives that's been kind of building up for years, but it's been recently established, is ECRADE, the European Clinical Research Alliance on Infectious Diseases. So this is a consortium that works across clinical settings. So it works from GPs to first aids, wards, ICUs, long-term care facilities. It works across infectious diseases, so it's not limited to sepsis or a single organ-specific disease, and it also merges stats and epi knowledge, biological research or microbiological research to the clinical research. I think that's one of the things that can improve collaboration, and it also establishes that stadium, that operational infrastructure for studies. So in conclusion, yes, research can be much improved if we collaborate, if we use smart designs, established operational infrastructure, and if we address inequality. Thank you for your attention.
Thank you, Lenny. Do you want to ask a question? Oh.
No.
Lenny, we have 1 minute for a comment. It's amazing what you have done with Remap Cap and also recovery. I mean, the thousands and thousands of patients, but the potential is so much bigger than that, and I have the feeling that bureaucracy is still holding us back. What are we going to ask, or what do we need to do at European level, at international level, so that IRB ethics approval are streamlined and prepared before?
That's actually a crucial question. This is what I tried to refer to with my pearl hurdles in the slides. So this is really something that has to be addressed by talks between investigators and funders and legislators or regulatory authorities. So some of the information I shared is from a viewpoint we wrote in Lancet Infectious Diseases that was complemented by reflections from the funders and the regulatory authorities. And I think that gives you a kind of a good framework for what needs to be done. But it needs to be on a high level, and you can't solve that kind of on the ground. And I think that's one of the challenges we'd have to solve before the next pandemic to be even faster than we were now. Absolutely.
Okay, thank you very much. Thank you very much for this fantastic presentation. And again, sorry for the technical issues you experienced at the beginning of your presentation. So now I have the pleasure to invite Charlotte Bradbury from UK, Bristol. So she will present the results of a study, the role of platelets, anti-platelets agents, in COVID-19 patients. Thank you very much.
Thank you. Thank you so much for this opportunity to present today. I'm going to be talking about antiplatelet agents in COVID. I'm a consultant hematologist. And I'm delighted to be able to include some new data from the antiplatelet domain of Remap Cap, published in JAMA today. So just as a bit of background, thrombotic complications are very common in patients admitted to hospital with COVID-19, in spite of standard thromboprophylaxis. Patients at highest risk are those who are critically ill in intensive care. Thrombosis can occur in venous, arterial, and microvascular circulations, as well as extracorporeal circuits, such as those used for renal replacement therapy. Thrombosis can affect the lungs, heart, brain, peripheral vasculature, and mesenteric circulations. And it's now really thought that thrombosis is a key contributor to clinical deterioration, organ dysfunction, and death for many patients with COVID. What we often see on postmortems is widespread thrombosis of the pulmonary vasculature, both small and large vessels, with associated inflammation. So why are patients at such high risk of thrombosis with COVID? There's a profound systemic inflammatory response to the virus that drives hypercoagulability, but there is also direct infection of the virus of the vascular endothelium via ACE2, which results in damage, activation, and local vascular inflammation. So the result can not only be macrovascular clots in arteries and veins, but also microthrombi, which will contribute to organ dysfunction, including ARDS. So within Remap Cap, we were very keen to ask whether escalated antithrombotic strategies could improve outcomes for patients hospitalized with COVID-19. And we've assessed two classes of antithrombotic drugs within two domains. So therapeutic dose heparin within the anticoagulation domain and antiplatelet agents in the antiplatelet domain. We were also particularly interested to understand the interaction between these two classes of drugs, as there's not only the potential for synergy, but also risk, particularly in terms of bleeding risk. And I'm pleased to say that the therapeutic anticoagulation domain results have been published, as I'm sure you're aware. But the take-home messages are that therapeutic dose heparin doesn't improve outcomes for critically ill patients with COVID, but does improve outcomes for non-critically ill hospitalized patients. So moving back to antiplatelets. And in the antiplatelet domain, patients were randomized to either no antiplatelet, low-dose aspirin, or a P2Y12 inhibitor. interventions were continued for 14 days or until hospital discharge. And we recommended gastric protection alongside the antiplatelet therapy. We were very mindful that patients were also on steroids and thromboprophylaxis. It's a pragmatic trial, as you've heard many times, but essentially, if there was a clinical indication like bleeding or thrombosis, clinicians could stop or change treatment. And after 14 days, further treatment was at the discretion of the treating clinician. So, Remap Cap is an ongoing adaptive platform trial that tests multiple interventions within multiple domains. For the antiplatelet domain, over 1,500 patients were enrolled from 8 countries. 1,549 completed the trial, and about 500 were randomized to each open-label group. More than 90% of patients that were randomized to the P2Y12 inhibitor group received clopidogrel. And recruitment of non-critically ill patients stopped after 266 were enrolled before a predefined statistical trigger had been reached. So the primary endpoint of organ support-free days is a composite and an ordinal scale ranging from the worst outcome of -1 for death in hospital to 22 for the best outcome for survivors free from organ support over 21 days. Secondary outcomes included survival to discharge, 90-day survival, thrombosis, and bleeding events. The primary analysis was a Bayesian cumulative logistic model with an odds ratio of greater than 1 representing improved outcomes. There were predefined statistical thresholds for efficacy, equivalence, and futility. So if we look at the critically ill participant characteristics at baseline, we can see that the groups are well matched in terms of age, sex, respiratory support, and concomitant therapies, including immunomodulation and anti-coagulation. Nearly all patients had already received steroids, and over half had received an IL-6 receptor antagonist. All the patients with data available were also on anticoagulation, most commonly low molecular weight heparin at intermediate or low prophylactic dose. So the aspirin and P2Y12 inhibitor groups reached the predefined statistical trigger for equivalence. And although these groups continued to enroll separately, they were subsequently pooled for further statistical analysis. Enrollment then stopped when the pooled antiplatelet group reached the criteria for futility compared with control. So what we can see is that organ support-free days are 7 in both groups, with a 95.7% probability of futility. Hospital survival was 71.5% for patients randomized to antiplatelet therapy, compared to 67.9% for those without antiplatelet therapy, giving rise to an adjusted odds ratio of 1.27, with an adjusted absolute improvement in survival of 5% and a 97% probability of efficacy. This figure just shows the block representation of the proportions according to each category, with the darkest red representing death in hospital and increasing blue representing improved survival free from organ support. And I put this up here just to show you that the patterns are very similar for aspirin and P2Y12 inhibitor. So this curve shows the cumulative mortality over 90-day follow-up And we can see that there's a 99.7% posterior probability that antiplatelet therapy improves survival over this 3-month follow-up with a hazard ratio of 1.22. And we can also see that the curves for aspirin and P2Y12 inhibitor virtually overlap. So again, very similar efficacy. There was also a 99.7% probability of efficacy for the composite of thrombotic event or death, but this was primarily driven by the mortality signal. Overall, major bleeding was less than expected from observational data and the previous results from the anticoagulation domain. But there was a higher rate of major bleeding in those randomized to antiplatelet therapy at 2.1% compared to 0.4%, giving a 99.4% probability that antiplatelet therapy increased major bleeding. So if we look at the outcomes according to the baseline concomitant anticoagulation dose, we can see that antiplatelet therapy improved survival in patients receiving less than therapeutic dose anticoagulation with an odds ratio of 1.33 and a 97.1% probability of efficacy. However, the converse is true, so the odds ratio reversed for patients who were receiving therapeutic dose anticoagulation with an odds ratio of 0.63. So although this isn't conclusive data, it does strongly suggest that there is a harmful interaction between therapeutic dose anticoagulation and antiplatelet therapy for critically ill patients. So for the Remap Cap results, among critically ill patients, we can say that antiplatelet therapy, there was a low likelihood it improved the primary outcome of organ support-free days, but there was a high likelihood it improved survival to 90 days. Rates of major bleeding were low, but they were increased with antiplatelet therapy, not totally unexpected. And efficacy and safety of aspirin and P2Y12 inhibitors are remarkably similar in this context. There is a possible harmful interaction of antiplatelets in combination with therapeutic dose anticoagulation. So I'm going to mention the 2 other large antiplatelet trials and explain some of the key differences that might help explain some of the differences in the results. So recovery, as I'm sure you've heard of, more than 14,000 patients randomized to either aspirin or no antiplatelet therapy. And they found that 28-day mortality was not different with aspirin. They had a slightly higher proportion of patients discharged from hospital alive with aspirin. Recovery predominantly recruited non-critically ill patients. They used a higher dose of aspirin, so 150 milligrams. Their only exclusion for bleeding risk was recent major bleed. They didn't record or control the anticoagulation dose because it was a pragmatic all-comers trial with minimal data entry. They didn't have concomitant gastric protection recommendation, and actually the 28-day point for mortality may be a bit too soon. If you look at the survival curves from Remap Cap, they seem to diverge after this point. So what about the Active 4A group, a great collaborator with Remap Cap? A slightly more modest normal size trial of 562. They found that P2Y12 inhibitor didn't improve their primary endpoint of days alive and free of organ support at 21 days. But the published data so far is for non-critically ill. They use mainly ticagrelor, which is a much more potent P2Y12 inhibitor than clopidogrel. And most importantly, I think, based on our data, the P2Y12 inhibitor was given alongside therapeutic dose heparin. We're really looking forward to seeing the active 4A results for their critically ill cohort, which is still recruiting, and they're using a P2Y12 inhibitor alongside prophylactic dose anticoagulation in this cohort. So, to conclude, what is the place of antiplatelet agents in COVID? And I very much echo the previous fantastic talks. Just to say that at the beginning of the pandemic, there was such a reactive approach to treatment based on perceived benefit and a bit of anecdote that patients just were so much better once we started doing this or that. And escalated antithrombotic treatments were widely used, particularly in critical care. So in the UK, it was like the Wild West, you know, that there was literally any dose of anticoagulation, add in a bit of antiplatelet, you know, select patients according to D-dimer or some other non-evidence-based, indicator. But we're now, thankfully, finally in the era of evidence-based medicine from randomized trials and can make informed decisions on patients' care. And we've now got recommendations with actually some, class 1A evidence, which is fantastic. And this is all thanks to innovative, adaptive, pragmatic platform trials, the ability to both learn and do in the face of multiple unknowns. And for me, it's just been fantastic to be part of this unprecedented collaboration, both interspeciality, so as a hematologist, who'd have thought I'd be here talking in this meeting, but also international, and the patient and public willingness to embrace research. What we know so far is that in non-critically ill patients, the data doesn't support using antiplatelets. But from our data, antiplatelet therapy may improve survival at 90 days for critically ill patients. What we don't know is if, like therapeutic anticoagulation with heparin, this is a differential effect based on illness severity or timing, or is it another difference in the protocol, such as concurrent anticoagulation dose, eligibility criteria, or alternatives? And it is an area of ongoing research, and like you say, individualized therapy is the way forward, understanding who are the patients we should be giving this to. So I need to finish by just saying that I'm lucky enough, I'm very thankful to be presenting this on behalf of a very large international group of collaborators who it's been fantastic to work with, definitely the highlight of my career. And multiple national and international funders. In the UK, the NIHR has been key to funding the trial, and this is the disclaimer. Thank you.
Thank you very much for this fantastic presentation. We have time for one or two questions. Is there some question from the audience? If we want to move on a little bit and try to perhaps, let's say, see what kind of population can be targeted in the ICU and critically ill. What do you recommend?
So when we developed the Remap Cap protocol, we were very mindful of the critically ill cohort and paid a lot of attention to bleeding risk. So, for example, patients with a creatinine clearance less than 30 or on renal replacement therapy are known to already have platelet dysfunction and be at higher bleeding risk. So we excluded those. Also, I would not have patients on therapeutic dose anticoagulation alongside antiplatelet therapy unless there was a clinical indication that was bona fide for that combination. I know that our data isn't conclusive, but because it's very biologically plausible and we're mindful this group, when you have vascular inflammation, you can thrombose and bleed, that I think selecting patients is really key.
Maybe a general comment on these. Yeah. A general comment on this study, but in general also how we extrapolate the evidence then to bedside practice. Because let me just finish 1 second, in the sense that, especially during surge times of capacity, we often have critical ill patients outside of the intensive care. So who is a critically ill patient? Is it the one that is on the CPAP mask, even in a normal ward? And what would you recommend in these cases, when to start?
I think this is really interesting, and actually, so I've been involved in guideline writing for antithrombotic treatments, and actually telling the person, who's often a junior doctor, on the front line, which patients to treat with what, when. And there's been quite a lot of difficulty implementing the therapeutic anticoagulation's good on the wards, but when they get iller, stop it and change to something else. So I think that, you know, it is really important to try and be clear. You know, the ISTH guideline is currently looking at antithrombotic therapy and is looking at antiplatelet therapy. What I would say, though, is if you look at the multi-platform RCT, the patients who were on no oxygen or low flow oxygen are all in the non-critically ill. Whereas the kind of non-invasive ventilation and the invasive ventilation, I would probably classify those as critically ill wherever they are. But you're right, the trial definition's always slightly, you know, there's lots of people that seem to be in a grey zone, which makes it quite hard for the clinician.
Congratulations, and thank you for a fantastic presentation. So the next presentation is from Dr. Remy Coudroy. I hope I pronounce your name correctly.
That's perfect, thank you. So, thank you very much. It's a great pleasure to be here to present you the results of the Floridi IM trial. IM stands for immunocompromised. That compared high-flow nasal oxygen alone to non-invasive ventilation, alternating with high-flow nasal oxygen in immunocompromised patients with acute respiratory failure. So here are my disclosures. And this trial was funded by the French Ministry of Health and 2 private associations. And the Society of Efficient Healthcare provided high-flow oxygen devices and NIV masks for the trial. So there are more and more immunocompromised patients worldwide due to an increased incidence of cancer and also an increased survival of cancer. Most of these patients come to the ICU for acute respiratory failure, and the main issue is that when they require mechanical ventilation, their mortality rate is extremely high, more than 50% of cases. The European and American guidelines recommend the use of NIV in immunocompromised patients with acute respiratory failure, and this recommendation is mainly based on 2 randomized trials performed in the early 2000s that showed dramatic reduction of intubation and mortality rates as compared to oxygen. But these results have been quite recently, in the pre-COVID area, challenged by the IVNECTUS trial that included 374 patients and that did not show any difference between non-invasive ventilation and oxygen. However, this study suffers from some limitations. First, patients included had lowest respiratory severity at inclusion as compared to the 2 previous trials. Second, according to experts of NIV, NIV was underutilized with a mean daily duration of 8 hours within the first 24 hours. And third, the use of high-flow nasal oxygen was left at the discretion of the attending physician, and the use of high flow was more frequent in the NIV group, between NIV sessions, than in the oxygen group. Knowing that, the same year, the Floridi trial in patients with acute hypoxemic respiratory failure showed that high-flow nasal oxygen was associated with a lower mortality than non-invasive ventilation. And this difference of survival was even more remarkable in the subset of immunocompromised patients, because non-invasive ventilation was associated with a higher mortality rate than high flow. However, these results could not be extrapolated to all the immunocompromised patients because of the quite low sample size, because of the exclusion of patients with neutropenia, because, again, of the underutilization of NIV in the NIV group, because it was NIV sessions, and NIV was used in mean 9 hours during the first 24 hours. And this study raised some attention about the harmfulness of NIV. The harmfulness of NIV could be explained by the self-inflicted lung injury. According to this concept, the initial lung injury causes capillary leak, lung edema that will impair gas exchange and respiratory mechanics. That will lead to increased respiratory drive, increased esophageal pressure, and the adding of positive pressure with NIV could increase transpulmonary pressure and increase tidal volumes that will lead to capillary leak and lung edema, causing a vicious circle. So our hypothesis was that high-flow nasal oxygen alone reduces day 28 mortality as compared to NIV in immunocompromised patients with acute respiratory failure. So we designed a prospective multi-center randomized controlled study performed in 20 centers in France and Italy. And we included adult patients with immunosuppression, predominantly cancer, with acute respiratory failure, with a respiratory rate of 25 breaths per minute or more, and a PF ratio equal to or below 300 millimeters of mercury under high flow, NIV, or oxygen through a mask with a flow greater than 10 liters per minute. We excluded patients with a severe hypercapnia, patients who could strongly benefit from NIV, as patients with a COPD, cardiogenic pulmonary edema in the postoperative setting, patients with a severe shock, with impaired consciousness, with urgent need to intubation or do not intubate order, or a contraindication for NIV according to the French guidelines. Patients were randomized with a 1-to-1 ratio by blocks and stratified according to center and the type of immunosuppression. On one side, patients with a leukopenia or neutropenia or a hematologic malignancy, and on the other side, other patients. And patients were allocated to one of the two arms, the high-flow alone group and the NIV group. In the high-flow alone group, patients were treated with high-flow alone, with a flow of 60 liters per minute or maximum tolerated according to physiological studies, because this flow was associated with a strongest decrease in respiratory efforts. And in the NIV group, patients were treated with a NIV alternating with high-flow nasal oxygen. And we tried to overcome the limitations of the previous trial by increasing the daily dose of NIV. The first session lasted 4 hours and then were continued for at least 12 hours per day, at least. We tried to limit desynchronous by using dedicated ventilators. We tried to use protective settings, targeting expiratory tidal volumes of less than 8 mL per kg. And we tried to promote alveolar recruitment by using PEEP levels of 8 centimeters of water or greater. And between NIV sessions, patients received high flow as in the high flow alone group. Some interventions were common to both groups, as FiO2, which was set to target SpO2 of 92% or more. And the two treatments were continued for at least 48 hours until recovery, and their winning was predetermined using a common winning protocol, or until intubation with predetermined intubation criteria. And because the absence of diagnosis is a major risk factor for mortality, we encourage all centers to have an extensive diagnosis workup. The primary outcome was mortality at day 28 after randomization, and the secondary outcome include mortality at different time points in the ICU at day 90, day 180, the length of stay in the ICU and in the hospital, and ventilator-free days at day 28, oxygenation technique-free days at day 28, and some parameters of efficacy and tolerance. We pre-planned 3 sensitivity analyses. First, according to our strata, which was hematological malignancy or leukopenia or neutropenia, because in the Hilbert trial, this subset of patients benefited from NIV. According to PF ratio equal to or below 200 millimeters of mercury, because in the Floridi trial, this patient benefited from high flow. And according to the absence of etiological diagnosis, because as I said, it's a major risk factor for mortality. So we expected a mortality rate of 35% in the NIV group, and we expected a mortality rate of 20% in the high flow alone group based on the sub-analysis of the Floridi trial in the subset of immunocompromised patients, and according to a monocenter retrospective study we performed in our unit. So we target 280 patients to detect an absolute difference of 15% in the rate of mortality between the two groups, with a power of 80% and a two-side risk of 5%. We inflated the number of patients to 300 patients to account for loss to follow-up. So from January 2017, from March 2019, 497 patients were eligible for inclusion and 300 were randomized. 1 patient in the NIV group withdrew consent, and 299 patients were included in the analysis, 145 in the intention to treat population in the NIV group, and 154 in the high flow alone group. Patients were mostly male. Their age was a little bit higher than 60 years old. The cause of immunosuppression was cancer in 70% of cases, and there was about 50% of patients with a hematological malignancy or neutropenia or leukopenia at admission. At time of randomization, patients were randomized during the 3 first hours after ICU admission. Their respiratory rate was greater than 32 breaths per minute, and their PF ratio was below 150 millimeters of mercury. More than 70% of patients had bilateral lung infiltrates on chest X-ray. The diagnosis workup included chest CT scan in 2/3 of patients and bronchoalveolar lavage in about half of them. And the main cause of respiratory failure was a documented infection in 49% of cases. Specific cause related to the underlying cause of immunosuppression in 15% of cases, toxic cause in 5%, and we did not find any etiological diagnosis in 16% of cases. The initial settings in the high flow alone group was flow of 58 liters per minute. And in the NIV group, the mean pressure support was 7 centimeters of water, PEEP of 7 centimeters of water, an expired tidal volume of 9.6 milliliters per kg, and NIV duration was 11 hours in median during the first 24 hours. And if we count from randomization to intubation or randomization to 24 hours, the first of the outcome, patients spend more than 50% of the time under non-invasive ventilation. NIV was conducted through a face mask with an ICU ventilator in 80% of cases. After 1 hour of treatment, PF ratio was higher in the NIV group than in the high flow group. There was a trend, but not significant, for lower respiratory rate in the high flow group than in the NIV group. And there was a decrease in discomfort scale that was more significantly important in the high flow group than in the non-invasive group, meaning that comfort increased slightly more in the high flow group than in the NIV group, on 8 milliliters on a 100 milliliter analog scale. The primary outcome, mortality at day 28, was not different between the two groups. It was 35% in the NIV group and 36% in the high flow alone group. And as you can see, the two Kaplan-Meier survivor curves are almost perfectly superimposed. Regarding secondary outcomes, there was no difference in intubation rate at day 28. There was a slightly lower rate, 46% in the NIV group than in the high-flow group, but mortality of intubated patients was 64% in the NIV group and versus 51% in the high-flow alone group. Likewise, there was no difference in mortality according to the different time points, and no difference in ICU length of stay, hospital length of stay, ventilator-free days at day 28, oxygenation technique 3 days at day 28. Regarding sensitivity analysis, there was no difference according to the in survival according to the type of immunosuppression. Same for PF ratio at inclusion or according to the cause of respiratory failure. So as a conclusion, among immunocompromised patients admitted to the ICU for acute respiratory failure, intubation and mortality rates at day 28 did not differ between patients treated with high flow alone and those treated with NIV alternating with high flow. So the current recommendation on the use of NIV in immunocompromised patients continue to be challenged. I would like to thank all the investigators that helped us to finish this trial before the COVID era. And we're very grateful from the reviewers of the Lancet Respiratory Medicine, from the editors, from all the nurses and all the patients who helped us in this trial. Thank you.
Thank you and congratulations on your study. Any questions from the audience? Otherwise, maybe I can start. If I understand correctly, all patients receive the treatment only in the intensive care.
Correct.
Do you have any data between the development of respiratory failure in the ward and when they started to receive the form of support? And in that case, whether did you see any differences in that subgroup based on time?
No, unfortunately, we don't have this kind of data. We randomized patients as soon as they came to the ICU for acute respiratory failure and as long as they meet the inclusion criteria.
Okay, and how's your practice at the moment after this study in your hospital?
So we don't use NIV because I think in my units we use NIV through a face mask. We don't use helmet NIV. And it's very tricky to obtain low tidal volume or protective NIV settings with NIV. So we use high flow mainly.
So that was my point. How do you deal with the almost 10 milliliters per kilo of tidal volume, you know, in the NIV group?
So expiratory tidal volume was very high. We target low tidal volume, but it remains very high despite quite low pressure support levels. So it suggests that these patients included in this trial had quite high respiratory drive. And maybe for these patients, it's not reasonable to do NIV because it's very difficult to reach protective settings. However, some very physiologic data show that it could be very interesting to individualize the settings of NIV and to individualize treatments. But it requires an esophageal pressure probe, and it's not very easy at the bedside for all patients.
Okay, thank you very much for this fantastic presentation. No, it's my pleasure, real pleasure, to it's my real pleasure to invite Professor Mervyn Singer from London, UK, to give the lecture, the Max Hariwal lecture, Lessons from History.
Merci, Jacques. Hi, everyone. Oops, put my glasses on. Right, let's see. Right. First of all, big thank you to Jean-Louis for inviting me to give the Max Hariwal lecture. For those of you who don't know, he was one of the founding fathers of critical care and perhaps as importantly, the mentor for Jean-Louis. My initial talk was lessons from history, and I was struggling. I probably could have given a 2-hour lecture. There's so many things out there that basically somebody thought of 50, 100, 200 years ago that we rediscover in now the 21st century. But obviously, I've got 20 minutes, so I thought, okay, what shall I focus on? And unfortunately, we've had a rotten 2 years with COVID, and you know, sadly, we've got the tragedy that's unfolding in the Ukraine. So I thought, okay, let me just focus on these things, and they are horrific. You know, and yeah, my heart goes out to the people of Ukraine, and so I'd like to actually show the positives. There are unfortunately some positives from war and pandemics and epidemics. So I'd like to basically, you know, sort of stress the small positives. We hate war, and I'd like to dedicate this to the people of Ukraine, and actually, as importantly, our colleagues in Ukrainian hospitals. Okay. Let's start with quarantine. The Black Death wiped out an estimated 30% of the European population, and clearly pandemics were a problem. They didn't know the cause, but they knew that they could be passed on often from one person to another. And so the Venetian Senate in 1448 decided to introduce quarantina, isolating ships and people to prevent spread of contagious diseases. And you can see here, you know, if it comes up there, ships flying a yellow flag indicated that they had yellow fever on board, and they, again, had to quarantine for 40 days. I bring us forward to the present, and we had actually a slightly shortened quarantine of 27 days for the Diamond Princess in Yokohama. PPE. Nothing new. 1656, 2020. Plus ça change. Let's wind forward to the polio epidemic in Copenhagen in the 1950s. Although, actually, to be fair, the Americans got there first. So Bauer and Bennett. Bauer was a clinician at Los Angeles County Hospital, and Bennett was an engineer, and he went on to found Puritan Bennett. And they described in a number of papers quite widespread use of tracheostomy for polio victims. They actually combined positive pressure ventilation with negative pressure. And if I can get my pointer, no, it's not working. Anyway, the thing on the left is the addition to the iron lung. So basically there was a bit of positive pressure on top of the negative pressure and the use of neuromuscular blockade. However, that's not to belittle the achievements of what they did in Copenhagen. So in 1952, the font size has changed, 3,000 hospitalized victims with respiratory failure, polio, were admitted to one hospital, Blegdam Hospital, an infectious disease hospital in Copenhagen. They had up to 50 admissions a day, many children. They collected the very sick patients together in one area, and that's the origins of what we now call modern intensive care. And there was a multidisciplinary approach: doctors, nurses, physios, students, lab technicians, etc. The first prolonged use of positive pressure ventilation, you've got the medical student bagging the patient, but that then led on to the development of positive pressure mechanical ventilators. And Astrup, who worked in the chemical pathology lab, developed essentially what became bedside blood gas analyzers. Beforehand, it was very, very difficult to actually measure gases quickly, and he basically got, in particular, carbon dioxide measurements made very, very rapidly. And you can read the original papers, and they're wonderful reads. Ibsen, the anaesthetist who drove the intensive care management, and this is a picture of Astrup. And I'll just focus on one thing. He commented that people early on were dying of respiratory failure, but once they instituted positive pressure ventilation, they shifted the mortality away from the lung to the circulation. And he pointed out that actually positive pressure ventilation may have deleterious effects on the circulation. And he commented, 1954, overventilation is harmful, and he recognized the impact it had on the circulation. And I think we've seen exactly the same with COVID and the right heart. But it took about 50 years before the ARDSNet study came along to confirm that, yep, lower tidal volumes were actually safer. Quick word on vaccination. In fact, they'd been started in the 1930s for polio, but were abandoned because a lot of adverse effects and problems with sort of purity of the solutions. And actually, some people were given polio by the vaccination. However, the Salk vaccine came out in 1955 in response to the polio epidemics happening in Copenhagen, in the UK, United States, and across Europe. But you can see there, with all these headlines in these newspaper cuttings, there was even controversy at the time about safety versus efficacy. And you had campaigns, so you had, and obviously children were being affected, so lots of emotive campaigns for children. You had celebrity endorsements, Elvis. And you had these sort of shock horror campaigns. Look, 7 children, they all got vaccinated, oh, except Dad, and look where Dad ended up. Yeah. That might teach the anti-vaxxers a thing or two. And I also like this one. We have a cure, we have a cure. Bit late, darling. And when you come forward to COVID, mRNA vaccines were essentially not going anywhere fast. They'd been around for 20 years in clinical trials, but there was no commercial product. And then Pfizer and Moderna came along, and the rest is history. Okay, let's talk about penicillin and the impact of World War II. So you're all familiar with Alexander Fleming, who was a microbiologist in London. He went on holiday in 1928. He was apparently a bit of a messy researcher, and he didn't wash up. He left his Petri dishes in the sink. The window was open, spores flew in and landed on an exposed Petri dish. Blue mold grew, and that basically killed the surrounding staphylococci in the Petri dish, and you can see on the bottom right. He identified this as a penicillium species and called the release substance penicillin, and he reported it in actually quite a nice paper in 1929. Oh, gosh, sorry, the formatting's all gone wrong. But basically, he did nothing about it. That was it. Oh, interesting observation, full stop. So we had to wind the clock forward to 1938. Howard Florey was an Australian working in Oxford, and by chance he came across Fleming's paper. And he and his team at Oxford, which included Chain had sort of run away from Nazi Germany, started working on penicillin. Oh, let's try it. This sounds interesting. And they determined the chemistry, they purified it, concentrated it, made it in small amounts, and trialed it on mice. And there's the paper in The Lancet in 1940. They gave it to Strep pyogenes and Staph aureus and so forth, showing great results in these mice. And they did Fleming the honor of trialing it on the first patient, a policeman, Albert Alexander, in 1941. He'd got basically septic from a mouth scratch from a rose thorn. What he was doing with a rose thorn in his mouth, I don't know. Maybe holding it between his teeth to give to his girlfriend. Basically, it worked. The temperature fell, he felt better, the wounds began to heal. The problem was they ran out of drug, and they were having to collect his urine to try and recycle the penicillin, but they didn't have enough, and sadly he died, but they were encouraged by the early success. This was the middle of the Second World War, and Florey thought, oh, this might help in the war effort, so he went to America to try and upscale production, and various companies took up the challenge. And look at the tremendous increase in production in just 2 years, from 21 billion to 6.8 trillion units, which is quite phenomenal, isn't it? I'll show you a little Pathé newsreel. I've edited it down. God, say that quickly.
Industrial monument to the miracle drug. Mass production penicillin plant at Terre Haute, Indiana, one of many where the life-saving medicine is now being manufactured wholesale. Tons of mold like that you've seen on spoiled foods are processed by rapid fermentation. The penicillin culture is then dehydrated. Each fermentation batch of 12,000 gallons yields about 15 gallons of concentrated penicillin. Penicillin sodium salt is the finished product. Each batch is tested for purity, New Zealand white rabbits serving as subjects. Upon how they react depends whether the drug can safely be used for battle casualties with pneumonia, meningitis, gas gangrene, and other wound infections. Don't worry about it hurting them. Penicillin-injected rabbits are the healthiest in the world. They seem to enjoy their job of serving mankind.
I don't think they asked the rabbits, though. And whatever happened to Fleming? Well, essentially from making a chance observation and not doing much else about it, he was knighted, he co-shared the Nobel Prize, and he became the rector, the head of Edinburgh University. Perhaps what's not so well known is, did he actually discover penicillin? And the answer is no. It was done in Manchester. This guy, who later became Sir William Roberts, was doing research to see if he could improve upon pasteurization. And he found that, again, he just noted 2 of his experiments where he had sort of cylinders and basically boiling them and seeing what happened, how long they stayed pure for. But in a couple of his experiments in 1872 and 1873, basically they got contaminated with fungoid vegetation. And they exactly resembled Penicillium glaucum. And he noted no bacteria were found. So he worked out that actually there was a connection, but he did nothing about it. But to give Roberts his due, he got there first. Okay, let's change tack. Death by drowning. So we're all familiar with lots of recent papers talking about trying to keep a good fluid balance and not allow positivity in our patients. Again, that got shown in the ARDSNet trial, 2006. A conservative strategy trying to maintain fluid balance was much better than just allowing the patient to remain positive or become increasingly positive. Again, nothing new. This is the original Ashbow, Petty, etc., ARDS paper, Lancet 1967. If you look at the right-hand column, look how often fluid overload comes into the story. So again, it was noted at the time. And this paper was driven by experiences gained in Vietnam. Even in the Second World War, they'd recognized that patients after resuscitation were developing wet lung. And clearly in Vietnam, there was much more sort of evacuation, much more aggressive treatment. And so you had shock lung, wet lung, Da Nang lung. Many were evacuated to Da Nang. And they saw respiratory failure occurring a few days after the injury. And they commented at the time, and this is a paper from 1973, basically overzealous administration of liquid, particularly of crystalloid solutions. So again, they'd even recognized at the time that perhaps drowning our patients wasn't such a good idea. And certainly when I was a junior doctor, many, many years ago, a bit later than 1973, the patients were routinely like Michelin men. And I was told, when I queried the logic of keeping them like that, I said, oh, don't worry, it's cosmetic. When they get better, it goes away. I queried that at the time. Let's go back to the very first description of intravenous saline. Again, this time not a pandemic, but an epidemic, cholera. And this came, again, in the Lancet from Dr. Latter in Leith, which is just outside Edinburgh. And you'll see there, he used intravenous saline, and you can see a beautiful picture in that paper in the Lancet. Basically, he's never yet seen one bad symptom attributable to it. I've no doubt that when judiciously applied, it will be one of the most powerful, the safest remedies used in the collapse stage of cholera. However, 5 months later, he basically slightly retracts that. Basically, those who've deemed giving saline worthy of a trial have often been disappointed by the evanescent, the short-term nature of the effect. To render these more permanent appeared highly desirable. Hitherto, what people have done is basically repeat the remedy, give more saline. Incredible quantities have been used, and I have no doubt sometimes evil consequences have been the result. Again, it's there, but we've just chosen to ignore it. The more two views are posed, the more likely the answer's somewhere in the middle. Colloid and crystalloid. So I have to declare a conflict of interest. Names are quite similar. Ringer actually was Professor of Medicine at University College London, hey, like me. And he came across it by chance. He was doing experiments on frog hearts and contractility, and the experiments weren't working. And one day they did. He couldn't understand why, and his lab technician confessed that instead of making distilled water, he was lazy and used tap water. And the tap water came from the New River Water Company, more on that later. And you can see it has different solutes, including calcium, which help the contraction. The New River was actually built in 1613 to bring water from the north of London into the growing population of London. I have to declare some interest there. There's University College, right at the bottom. I was born there, right close to the New River. I grew up there, right close to the New River up the top. So, you know, I grew up drinking Ringer's solution. And look at me now. But not everyone believed him. This is Bayliss. Bayliss was Professor of Physiology at University College London. He was the brother-in-law of Starling, and they worked together on many projects. But he gave this lecture at the end of the First World War, intravenous injection in wound shock, and basically Ringer's solution, although naturally one of the first to be tried, is useless. It leaves the vessels in half an hour or so, and the blood pressure falls back down. And he argues, why is this? It could be a low viscosity, or the fact it lacks a colloid with an osmotic pressure. So he was a big believer in colloids. And basically he said, what type of colloid? He dismissed starch and agar because it basically lacks an osmotic pressure. Likewise, dextrin lacks viscosity. Proteins, too much in the way of anaphylaxis and kidney effects. They're left with gelatin and gum arabic. Gelatin he wasn't so keen on because it contained tetanus spores, not good for the patient, and it could cause intravascular clotting. But gum arabic has none of these defects, and he basically reported cases in the First World War of intravenous gum arabic infusions with benefit. So maybe gum arabic that comes from the acacia tree is something we might revisit in the next 10, 20 years. Who knows? I'm running out of time. I better hurry up. Okay, what about blood? So again, First World War. Blood had been first given about 100 years ago to patients, but basically too many reactions. ABO grouping was discovered in 1901. But again, report from the First World War, an immediate and almost incredible improvement. Again, there was still transfusion reactions, so blood fell out of favor after the First World War. And this is my dog-eared copy of the Medical Research Council report in the management of shock and wound injuries in the Blitz in 1940, and then in the front line in Italy in 1944. You can see how the management changed. At the beginning of the war, during the Blitz, you basically rested the patient, kept them warm, sometimes uncomfortably warm. You didn't undress them, and you delayed operation even at the risk of developing wound infection. It was thought harmful to operate on, even examine and disturb a shocked patient. And then you gave oxygen and sometimes drugs such as choramine, which is a vasopressor, or adrenaline. They basically didn't think about transfusion only as a last resort in small amounts. It was thought dangerous, you know, because you might start rebleeding before the surgeon was ready. and it could overburden the circulation, dilate the heart, cause pulmonary edema. Basically, it was thought useless to attempt restoration of a moribund patient. But they learned, so by the time they got to Italy, they were giving blood, and much more freely and much more early. And basically, they seemed to do much better. If you delayed giving the transfusion, they did badly. So again, they learned the lesson from the war experiences. And the other quick comment I'd make there is how much blood you give. And they recognized that just looking at blood pressure is essentially fairly useless. So, let's just get the systolic up to 100 or above. But basically, they found that that was okay at rest, pushed the patient a little bit harder, and they quickly collapsed. And so, as you see down the end, restoration of blood pressure doesn't mean the blood volume's been restored to normal, usually that it's only been raised to a critical level or above. How far above is uncertain. Last two slides, a quick mention of this great guy, Larrey, Jean Larrey, who was Napoleon's surgeon. You can download off the internet a translation of his brilliant book. Sorry, again, with the reformatting. But he, amongst other things, I'll give two quick examples. Triage. Those who are dangerously wounded should receive the first attention without regard to rank or distinction. They who are injured to a lesser degree may wait until their brethren in arms who are badly mutilated have been operated on and dressed, because obviously survival matters in those critically ill patients. And he also developed the art of pre-hospital medicine, ambulance volante, in the Battle of Metz, a first-class surgeon major with a contingent of paramedics, including apothecaries, a farrier, a saddler, a bootmaker, a bearer of surgical instruments with a trumpet, and a lad with a drum carrying surgical dressings. That was the team. I'll finish there. I think war, pandemics are terrible things, but a small mercy, they do accelerate progress in medicine. Thank you very much indeed for listening.
Mervyn, it was fantastic, as always.
Thank you,
and
Marita.
With this, I would like to thank my co-chairman, Jacques, and also the chairman, Jean-Louis and Fabio, and every speaker, but really Jean-Louis and Fabio for bringing everyone here. It's fantastic to see so many friends and faces after 2 years. So I hope you enjoy the Congress. Thank you. Very good, very good. Very well. And perfect on time. So yeah,